Okay, so it's about 1 minute later now, and we're going to start. I'm Tom Burke, and Scott Klein, who organizes these things so well, saw me getting ready to come up on the stage, and he said, I, I thought okay, just a little technical difficulty there as we broadcast out to the internet and the entire world. So Scott said, Tom, I thought the big dean was going to be here. And I said, no, it's just the tall dean. I'm actually Associate Dean for Public Health Practice and Training, and I'm delighted to be here in the first of our new Moments in Leadership Grand Rounds. And I'm delighted. So the big question, and we've all seen changes. So it's been 70 days, 71 days, and so, well, the president's preoccupied now with the Queen, but is thinking about public health. And we're going to get insights tonight. And we have a great group of speakers to examine the changing of the guard, strategies to advance public health in the Obama administration. And I want to this effort has really been a team effort. And I want to thank, first and foremost, my colleagues in the Public Health Practice Committee and the Department of Health Policy and Management, who put our heads together, were able to put together the concepts for this Grand Round series and get a little funding and support from Pfizer and a lot of support from the school to make this possible. And I want to mention the other groups that helped us so much: the Maryland Health Officers Association, and we have Fran Phillips and Roger Harrell here, the Maryland Public Health Association. I want to really thank Molly Mitchell and Melanie Bird from the Mid-Atlantic Public Health Training Center, the Mid-Atlantic Health Leadership Institute, and also the Department of Health Policy and Management for putting up with us as we pull this together. And without further ado, I want to turn it over to my colleague who will be introducing the first speaker. So, Keisha Pollack.
Thank you, Tom. Good afternoon, everyone. Thank you. So our first speaker who will be coming up to share some insights with us is Dr. Linda De Gudas. It's always nice when you can invite a colleague and a friend to come here, and I'm so grateful. We're all grateful that Linda traveled down from New Haven to come be with us today. Dr. De Gudas is an associate professor of emergency medicine and public health, an associate clinical professor of nursing at Yale University. Her bio is very long, so I'm just going to highlight a couple things that I think are important and really, I think, characterize some of Linda's work. She was, first of all, a Robert Wood Johnson Health Policy Fellow working in the office of Senator Paul Wellstone for a few years. His research area has been mostly related to alcohol and injury, with a particular focus on interventions and policy issues. Her current work at Yale is focused on disaster preparedness, public health systems, and services research development. She's also the immediate past president of the American Public Health Association and has served 2 terms as chair of the APHA Executive Board. Dr. De Gudas is currently a member of the National Advisory Board for the Robert Wood Johnson Foundation Health Policy Fellow Program and Board of Directors for the Advocates for Highway and Auto Safety. So please join me in welcoming our first speaker, Dr. Linda De Gudas.
They're going to do it, I think.
Oh, okay,
Yeah.
great.
Thanks, Keisha. It's great to be here and good to see so many of you in the audience. I think slides are coming up. What I'm going to talk a little bit about what I think needs to be done in order to advance public health in the new administration. But I hope that you will see this as a call to action for everybody who's here and who's listening, for things that you need to keep in mind and things that you need to do in order to make things change, because you can't depend on somebody else to do it or depend on somebody else to except for the AV. Depend on somebody else to take care of it for you. We all have to be advocates for public health, and I think, here we go. That's it, yeah. Great, thanks. So, okay. So that's the message. So really think about how you can use this information, and I think what the other speakers are going to present in order to really make some change and get public health into the debate about health reform, because it hasn't been in there before, and we need to be the ones to make that change. First of all, we have this great opportunity. At this point in time, there really is political will and public will to do something about health reform. And I think more so than any of the prior attempts, we're hearing people in communities talk about health reform. They're talking about things that they need. They're talking about what is missing, what they can't get access to. And there is now also political will to do something about health. But one of the challenges that we have, and I think it's one of the biggest challenges, is moving from the focus that there has been on health care and treatment of disease to focusing on health and the health of the community. How do we make the community healthy? How do we do population-based health? How do we make sure that we're meeting the community needs and local needs with the regional and national efforts? And those are policies, those are programs, any of those kinds of things. Because most of what happens really occurs at a community level. And it really involves looking at what the values are of a specific community, what the culture is, what those people in the community need. And the final challenge is prevention, is getting people to understand that prevention is important, that prevention is the way that we are going to reduce costs, the way that we're going to really prevent larger costs in the future. And it's one of the things that has had very little focus in any of the talk about health reform. Keep in mind some of the factors that contribute to health. Obviously, the social determinants of health are something, again, that have not been discussed a lot in talking about health reform. We talk about the economy, we talk about how it impacts health, how especially now that we see a lot of people who had very high-paying jobs who don't have health insurance anymore. We're hearing now about how it's affecting them, but we haven't looked at the economic status of people, the 48 million people who are uninsured, and the number that keeps going up. Think about education and how that impacts health, and housing, nutrition, obviously the built environment, transportation. We have a great opportunity this year as far as transportation goes with the reauthorization of the transportation bill. Safety Lou is what the bill is being called. There's lots of opportunities in there, not just for things related to safety, passenger safety, pedestrian safety, that kind of thing, but there's things related to building of roads and to advocating for when roads are built, to have places for people to walk alongside the road that are safe, for places for people to bicycle so that they get exercise, so that we help prevent obesity and prevent other diseases. Agriculture obviously is another issue, and we're seeing a lot of issues right now with food safety, certainly a big piece of health. And then access to services, and those are preventive services as well as treatment services and coverage for those services. So I think, what I wanted to really see is the core principles I think that we need to get across in order to include public health is that health is really central to any kind of community that functions well. If we want a community to be viable, to be growing, we need to have it be healthy, and we need to do something to create that health. And it's not only health care. Treatment for illness is just one part of health. Unfortunately, it's where we spend a whole lot of money. But we also spend most of the money in treatment in the last 6 months of life. We're not spending a lot of money in prevention, and that's where we need to start looking to see where we can have some of those savings. And I would encourage you to think about prevention, and prevention being primary, as Larry Cohen would say. It's not just the preventive health services either. One of the things that happened that I encountered when I was working on the Hill and I was going through orientation, we'd go in and we'd be talking to somebody in the orientation, and I'd say, well, what about prevention? And they'd say, oh, you mean mammography and colonoscopy? And I'd go, no, I mean speed limits, And they go, well, that's not health stuff. I go, well, yeah, it is, because, people crash and they get killed, and then there's no trauma system to take care of them, and, all these things happen. Oh, no, but, we're only focusing on reimbursement for mammography or flu vaccines. Not that that's not important, but there's a broader area of prevention that nobody's looking at. They're not looking at the built environment. They're not looking at these other things that we in public health look at. So I think we need to keep that in mind, and we need to remind people that these are really important pieces of health. And so some of the critical elements of health reform and things that we need to really work on making sure are in health reform, investing in population-based and community-based prevention, addressing the underfunding that we've had in the public health system itself. We know the system is underfunded. We know that there aren't enough services in the public health system to go around. We haven't integrated the public health system as well as we can with other organizations and agencies that actually deal with projects and programs that affect health. We need to be better about assessing cost savings that result from prevention. We have some studies, but we don't have enough to really effectively convince people that prevention really is making a difference. We need to reduce disparities, and we know that those exist in essentially any community. And we need to look at the impact of policies on health, and that's not just health policies, but it's policies that we do in general. Any kind of policy that's passed at a state level, a local level, a federal level. How does it impact health? Does it take money away from health services or prevention? Does it actually create something that is a hazard and that really puts people's health at risk? We need to do something about having maybe a health impact score when we're passing policies or putting policies together. We don't do that very well. I don't think anybody's really been doing it at all, not even not very well. So if somebody can come up with a brilliant idea for doing this and calculating the health impact on any policy, it'll be great, but we need to advocate for it being included in any policy. And we need to start asking those questions. We need to say, so what's the health impact of this? What are you going to do? You're going to build this road. Well, what's going to happen to the health of the people? You're going to put this power plant over here. How are you going to protect the health of the people who live near it? What are you going to do? So ask the questions when you have an opportunity. Some other critical elements: comprehensive coverage for services. That includes the preventive services, and they should be evidence-based. I think that's our other opportunity, is that science actually is now considered believable. So I think we have that opportunity to use science, to use the information that we have about what works, and promote getting programs that work and services that work out into the community. We need to include behavioral health in any kind of coverage that we provide. It's mental health and substance abuse treatment parity. Some people think that now that we have it on certain levels, it's there, and it's not there. We don't have access. We don't have parity for everybody. We need to not just pay for performance, but we need to pay for prevention. Paying for performance is great, and we really focus on quality, but I think we need to pay for prevention as well. And a lot of people will tell you that the reason they don't do things, they don't implement preventive services, is there's no reimbursement for them. So they can't really afford to do it. Public programs, we really need to make sure that the functions of the safety net that includes community-based services are there. And we need to take the focus away from emergency departments as a safety net. They're overcrowded. They're really functioning way beyond their capacity. I don't know what will happen in some places if we do have any major events that really increase the need for emergency services. So it's really not the place to have people go as a safety net provider. And we need to really include insurance options, public insurance options for people. The workforce is another big area. We know that the workforce is aging. We know that even in affluent communities, people can't get access to a primary care provider, because what happens when people go to, a lot of people go to med school and go into specialty programs. I was just up at a state school where they have 120 students who graduated. Generally, most of their students, or 50% of their students, would go into primary care. This year, only 2 students are going into primary care. And that's probably because the reimbursement isn't very good for people in primary care. We pay pediatricians less than we pay cardiothoracic surgeons or plastic surgeons. We pay primary care practitioners a lot less than we pay people who are doing elective surgery. So I think we need to look at that and kind of figure out how to equalize that and really pay people to provide good care and good preventive care to the population. And then we really need to have provisions for funding the research to find out what really works in policy and prevention so that we can advocate for it. So what do we need? We need, as I said, consideration of health in the broad sense in all policy, a focus on health that in a broader sense than disease treatment, including the public health system and health reform, universal coverage and access, because coverage doesn't guarantee access. You can have coverage, but you can't find anybody to see, or the clinic's only open during the time that you're working, and you can't take a time off from work to go to the clinic because you don't have that kind of time. And we need to pay for prevention. And I think those are the only ways that we're really going to get to the goal of having a nation where we have healthy communities that can help support our economy, that can help support what we really want to be. So I think I'd ask all of you to get out there and start advocating for public health and advocate for including it in health reform. Talk to your neighbors, talk to your friends about it, and really help us all move this forward. Thanks. We'll do questions at the end.
Thank you, Linda. I'm Beth Resnick. I'm going to be introducing our next speaker, who is Dr. Shelley Hearn. I think a lot of you might already know Shelley Hearn, who's a teacher here. But actually, I always think it's great when you get to read someone's bio. You get to learn lots of new things about them. Good things, good things. When we started to put this idea of this panel together, we really wanted to think about who really could make change happen. Shelley Hearn immediately came to all of our minds because really she has such a tremendous background. But in addition to all of the things she's accomplished, she really has something unique in the sense that she has different perspectives. She's been here, so she has the academic piece. She's been in the practice world. She was at the New Jersey Department of Environment, Environmental Protection. She's been an advocate. She was a founding director of the you've been in so many places, I forgot the name of it, Trust for America's Health, which did a lot of advocacy work in terms of trying to promote public health in the public health system through state and local health departments. And the other things I found out about her that I did not know was that she has the science background too. She has her bachelor's in chemistry and environmental studies, and then she also has her doctorate in environmental sciences from Columbia University School of Public Health. So with all of that, I'd like to introduce Dr. Shelley Hearn. Thank you.
Beth was very kind. She knows that with all my stupid jokes, it's a little shocking that there would be a science background. Policy, right? Policy and science. Well, I'm here to talk that they're, as a good Jersey girl, they're perfect together. And talk a little bit why, at this point in time, in fact, there's more hope than ever. But I have one sidebar. If I know this is on the web, but I am a little disappointed. I was supposed to go last, and my understanding was there is another speaker, and I'm going to fill in. But that if she was late, that Tom was going to talk instead about his injury prevention work and Wii Fitness and do a demonstration piece about how to use the hula hoop properly. Didn't you say that? Right. All right. Let's get back to science. I appreciate Linda is always a wonderful person to work tag team. We've had the opportunity with American Public Health and other places to take a look at how do we advance issues, how do we move policy, but in a key way to how to do it pragmatically. And it's been a challenge in the past few years. And we're actually, as much as we have a new administration in, and I know hope is an operative word, let me just be a little grim for a moment and have some reminders of the challenges that we face. I'm one of those people that thinks that we're not in a recession. We're, in fact, not using the D word. Am I allowed to use it here? I think this is the new Great Depression that we're about to enter, that we have started to. Record home foreclosures. We have banks no longer functioning. We have an unparalleled time in terms of economic crisis. We are now owners, we collectively, of some of the major car manufacturers, insurance companies, and some of the banks. This is a time we've never experienced before, and it's going to be a challenge in terms of how do we move some of the issues that we care deeply about, that the science tells us needs to be fixed today, when we have a struggle going on for actual economic viability of this country. You asked me to be optimistic. Did I start off well enough here? Thank you, yeah. David, I knew I could count on you for a good cheer there. I think it's important because I also appreciate Linda opened up with healthcare reform. And my optimism is I do think we are going to see this issue finally have its day. I'm actually one of those people that is rooting for the House to put in the reconciliation provisions so that the Congress will be, the Senate, could actually have a 51 vote to get budget dollars through so that there actually would be an investment made and break through some of the old politics and have a chance for both health care reform. And the other major issue out there is global climate change. If we're going to do the blend of politics and public health, to borrow from a past presidential candidate, the giant sucking sound out there on policy reform is health care and global climate change. So that's the good news. That sounded like good news, right? But there are many fundamental issues on public health that are critical to our issues that are not necessarily in those titanic policy issues that are moving. Issues such as drug safety reform, issues such as conflict of interest in our medical schools, the roles of pharmaceutical industry and education to physicians, the role of food safety, the role of childhood obesity, and many policies associated that should be their time. Issues such as basic consumer product safety. I even include issues such as credit card reform as a public health issue. Because if we have a majority of Americans being impacted with losing their discretionary income because of predatory practices that are hidden and embedded in their loans, whether they be home foreclosure issues or actual use of the credit card, those are public health issues. And is now the time that we can pass those? Well, I actually going to keep looking for political advice in terms of my hopefulness. I look at President Obama's chief of staff, and I think there's his rule number one is never waste a good crisis. Never waste a good crisis. And in fact, that's the experiences we've had in the past. The Great Depression was an extraordinary pivotal time for massive change and reform in political practices. I follow and cheer for the two Roosevelts that we've had at the helm, that we've had some extraordinary lessons, that Franklin Roosevelt seized that opportunity of an extraordinary depression to put in place some of the most profound public health programs in our history. Teddy Roosevelt is actually one of my heroes. In New Jersey, Republicans, Democrats, they kind of one and the same. Really. People are not normal from New Jersey, are they? It gives me a little hope that I often look at public health issues as an equal opportunity. They're not owned by one party. And I think it's we've had some of the best champions for public health from alternating sides of the aisle. And maybe that's because no one always wants it or is the champion of it, but in fact it's some of the greatest opportunities to advance political change. Teddy Roosevelt is actually the greatest consumer advocate that we've ever had in the presidency. Back in 1906, he was the one that put in place the rules to have our current FDA. He championed the food safety laws. He championed the drug safety laws. Upton Sinclair was doing quite a bit of journalism at that time to put the issues out there. But it was Teddy Roosevelt who actually, without even that stimulus, was spending his political capital at a time of crisis to move these issues forward. And I actually think this is, in as much as we have a crisis in front of us, it is a crisis the public health can effectively seize to help move many of the issues that we're passionately caring about. And it's not simply by attaching ourselves to the coattails of healthcare reform or trying to weave into the global climate change debates, which, while talked about for this year, I think that may in fact be the 112th Congress, but I wouldn't put money on that one. I think that what it really comes down to, the hope that I have in terms of doing the political calculus as to why I think we'll actually see the food safety law pass this year. It might even pass before healthcare reform. I think there are going to be some very significant drug safety laws that have a chance of moving also during this term. I think that we may in fact see some of the credit card reforms simultaneously move, where in the past, if you wanted to pick a losing bet, credit card reform was the best one to put your money on, because the banking industry was absolutely impossible to have any hope to pass legislation in that arena. Well, all bets are off right now, and the world as we know it is quite different. And there are three pieces that I take a look at to make determinations as to how we're going to move them and why I have extraordinary amount of hope right now. One is leadership matters. Leadership matters profoundly. And you take a look at the appointments that are coming down the pike in the issues that we care about in public health. And I practically want to pull out the hula hoop and do the jig, and despite the possible injury threats out there, I'll stick to science. We have Peggy Hamburg as the proposed leader of FDA. I don't know how many of you know Peggy, but Peggy has been an extraordinary champion right from the get-go. I think she started at age 12, perhaps because of her parents. But from the helm at New York City's Department of Health to the federal government, to actually had the good fortune for her to serve on the board at Trust for America's Health, she was a stalwart in terms of tell the truth, trust the people, put the information out there, put the facts out there, and stick with them. And riding right with her is one of my absolute poster child for a physician advocate is Josh Sharfstein. And I am going to do a jig right now, just in pure happiness, that if that's the team that we're going to have at FDA, it has been the Cinderella agency of the Public Health Service, the largest regulatory agency in the country, and the most forgotten one. And if any of you are working for the FDA right now, I thank you immensely for having the bravery to have stayed, because we need you there. But I actually hope that we have now an opportunity to put more and more, and furthermore, more experts back into the agency and making the decisions that they're finally going to have a chance to make. Because what has happened is, as a paralyzed agency, it's not been able to do its job. So whether it's making a decision that they wanted to do 30 years ago, which was to ban the non-therapeutic uses of antibiotics in industrial farming, which the veterinarian community said you absolutely must do, FDA wanted to do, but the politics got in the way, and here we are debating it today. I think that's a reform package which actually has a chance, probably not this year, but 2 years, and part of it because the leadership that's going to be coming into the agency to once again stand up and let the science speak for what needs to go forward on the facts. So leadership matters. I can go on in the litany of who else is coming in various agencies, but then I'd be doing too much dancing up here rather than talking. Leadership matters. Science matters. That's the other message that we've gotten loud and clear. And I almost got a little weepy with the inaugural, it's not really an inaugural, the quasi State of the Union. The first time President Obama spoke to Congress. Wasn't technically a State of the Union, but that's Washington speak. Where in there, he noted that he's making a commitment to restore science to its proper place. Just a few little words, but got me all choked up. And it should give all of you the reason to have faith that we have a chance here for true public health reform, because if science matters, then that's the opportunity we have to put special interests aside. If facts can be in a place to help drive decision making, not just politics, not just passion, but facts that are translated and engaged in the science making and the policy making, that's what's going to also give us a chance to have actual public health policy reforms. And the last part that is a critical element is that the public and their re-engagement in the political process is going to be the winning ingredient. A lot of these basic public health consumer safety issues have been off the radar screen. People have not paid attention. The public is mad. Whether it's food safety, it's peanut butter yesterday, pistachios today, and it will be something else tomorrow, and it's finally on the radar screen. Or starting to understand the role and relationship of the pharmaceutical industry burying science from informing good decision-making in pharmaceutical drug use. Along with a long line of other activities, the public is recognizing that it's not okay, their voice matters, and is re-engaging in a political process that the polling data that we've been tracking in terms of many issues that the public just didn't care about and didn't think were going to change, and what did it matter? Today, many of these issues that were back burner are off the charts. And that combination of political will, the leadership in the right place, and the return of science to decision-making is where I think that it's truly a changing of the guard, not just of new people, new administration, but it's a new political will out there and revitalization. So I actually think this is going to be public health's time, not just healthcare reform, not just global climate change, but an extraordinary advancement of some very basic public health fixes that in some instances haven't been fixed since Teddy Roosevelt in 1906. So now I'm going to do a jig and leave you to thinking about all that. Thanks.
Well, thanks, Shelley. And I think if you're going to do a jig, the least we could have is Tom do some hula hoop demonstrations. So it's all fair. Well, our third speaker today for the afternoon is Dr. Ellen Marie Whalen. And as Tom, Keisha, Beth, and I were planning this event, sitting around the table on many afternoons trying to decide who we could bring to the school to speak to this issue, it was very easy for us to come up with Linda and Shelley right off the bat. We're prevention folks. We knew who the go-to people were. But we realized that it was very important to also include healthcare policy in this talk. It's a huge part of what's being talked about in the nation. It's a huge part of what is happening with the new administration. But we weren't really the experts to do that. So as we were sort of exchanging emails one night, trying to figure out who we could tap to speak to healthcare issues in this Grand Round seminar, I decided to send an email to our friend Jerry Anderson, who I'm sure all of you know is on faculty here at the school and a preeminent authority on the issue of healthcare and how to do it right. So I sent an email to Jerry late at night and said, we're putting together this seminar series. We need someone from inside the Beltway who can really speak with authority as to where healthcare reform is headed under this new administration. And as is often the case when I email my Hopkins colleagues at the wee hours of the morning, I got an email right back. Jerry said, well, the person you need to contact, without a doubt, is Ellen Marie Whalen. She will do a fantastic job. She's got her finger on the pulse of what's happening in Washington. She would love to come back to Hopkins. She's the person you need to get. And I knew Ellen Marie when she was here, and I was happy to take up that suggestion and reconnect with her and invite her to participate. So at whatever hour in the night or morning it was, I sent her an email and expected to hear back in a day or two. I went back to the work that I was doing, and up popped a message. Sometimes, that part of Hopkins, I think, never leaves you. So Ellen Marie immediately responded that she would love to come. She was thankfully free on this day, and here she is to talk to us about what's happening with regard to healthcare reform in the Obama administration. Let me tell you a little bit about Ellen Marie. She has, in addition to completing a postdoctoral fellowship here at Hopkins in primary health care, she was also instrumental in sort of the early days of the Urban Health Institute here. She has worked at the University of Pennsylvania doing work with adolescent health there. So she's been on the faculty of schools of public health, of nursing up and down the Mid-Atlantic coast. She has also been the recipient of a Robert Wood Johnson Health Policy Fellowship. She has worked in that capacity. She worked in that capacity for Senator Tom Daschle. She's also worked for our own Senator, Barbara Mikulski, and she is currently with the Center for American Progress, where she serves as a senior health policy analyst and associate director of health policy. Again, Dr. Whalen, we are so pleased to have you here to talk to us about what's going to happen with our health insurance benefits and all the good things that are happening under this administration. So thank you for being here.
Thanks, Shannon. Yeah, it is crazy when we're all online at the same time and we're immediately communicating. I remember when G-Chat came on, I'm like, isn't that what email's about? You just kind of go right back and forth so quickly. I also can't believe this is the room where I had statistics. It looks completely different. It's such a beautiful room now. Yeah, it's this warm environment now. So I'm actually going to hopefully be a little bit more optimistic. I will try to move of where we're going. And I am going to be focusing not on the primary prevention that these folks took care of, and I'm moving towards across in HPM. And as Shannon said, I did a postdoc in primary care policy, and that was a while ago. And at the time, everyone was like, 2 years, primary care policy? What are you doing that for? And now suddenly, it's kind of the way we're going with payment reform. And people are like, really? You studied primary care? So it's been really fun to be in DC now when we're looking at hopefully trying to move Medicare and payment reform a little bit more in that direction. So what I'm going to talk about today, first I'm going to be a little depressing, talking about the state of healthcare in the United States. And none of this stuff is probably going to be new, but I think when you paint it in the picture, it's very clear on the direction we need to be going. Why now is the time for reform, why we shouldn't waste this great crisis, as they're saying. The two goals that we're trying to make sure that we do simultaneously, and some are pulling us in different directions, is covering everyone while we're trying to save money, and is that something that we actually can do? And then a couple of solutions. So first of all, are we getting what we pay for? And Hopkins is so international that it makes sense to look and see where we, on the end here of the 30 states, what we're spending on health care, nearly $7,000 per person on health care. And you can see of the 30 states here that no one's even close to spending that much per person on health care. And this shows actually how we're growing. So it's not just a single point in time, but this is over the past 25 years. Look at the growth rate of the United States, the top red one here, how we're growing cost-wise, whether we're looking at per person capita here or a percent of the gross domestic product. And you can see the other countries are all clustered and growing at different rates. So there's something very different going on in the United States. And this is what we have to focus on as we're making these changes. And are we getting what we pay for? Well, of course, you all know. Here's the United States here. And this is a life expectancy. Once you hit 60, how many more good years of healthy years do you have left? And you can see Japan, Switzerland here. Once you hit 60, you've got about 20 for women, a little less for men, of good years left. And we're way down here. In years-wise, it's not a whole lot, but you can just see in terms of how we have spent the money in terms of what we're actually getting. And this is, I love this one, especially as a primary care person. Mortality, so when you die because you didn't get the right health care. Mortality amenable to health care. And these are things like diabetes, heart disease, that if you had gotten the proper health care, maybe you wouldn't have, but you ended up dying from this. And this is a measure, obviously, that is used internationally. And we have more people dying from
preventable or from diseases that would have been hopefully taken care of if you got care in the right place. And where is the right place? And as Linda said, part of the problem is we've got folks going to the emergency room. And you can see here, this is folks that went to the emergency room when they probably could have or should have been treated someplace more appropriately. And the United States is way up here. We've actually done a little bit better in the past 2 years, but you can compare it to Germany, Netherlands, New Zealand, UK, Australia, Canada. These folks, the percentage of adults who are going to the ER when they should have gone somewhere else. And of course, infant mortality rate, and this is probably something I don't have to talk about here. You can see where we are internationally, but this is also interesting to show. This is the United States, where we are, babies dying before their first birthday. And then you look at the top 10%, the best states in the Union. And the best states are still not doing as well as most other countries. And of course, the worst states are almost up around 10, 11, the states that are not doing so well in infant mortality. And this is at the global big country levels. If we go down to more personally having us compared to other countries, what are we spending out of pocket, individuals spending on healthcare compared to other nations? And this one is what percentage of people with a chronic condition are spending less than $500 of their own, this is after you're insured or whatever else. How much, so 31% are spending under $500, and you can see more like half or up to 81% are spending it. And of course, the reverse then over here. What percentage are spending more than $1,000 of their own dollars on health care if you've got one chronic illness? And again, are they doing as well? These are the same countries. People with a chronic condition, how many times did you not fill your prescription because it was too expensive? How many times did you not visit a doctor when you had a medical problem and didn't get the recommended test? And over here, 43% of people, 36, 38% of people. And of all of these, so people with a chronic condition, over half said, people in the United States with one chronic condition, over half said that they answered one of these things, that in the past year, I did not do one of these things because I couldn't afford it. So we're spending way too much money, and we're having all of these people still not getting the health care that we need. Why now is the time? And as Shelley said, we don't want to waste a good crisis. And I think part of the issue is, and when I was in Tom Daschle's office and we were driving through South Dakota and there's no press around, and we're hearing these stories about people, and he said, Ellen Marie, I don't understand, why aren't all the members of Congress hearing this over and over and over again, that we have to do something on health care? And the problem was it never is urgent. And as you're pointing out, banking and all these other things, they end up getting to the urgency. And I was in the leader's office, and you had that view of, oh my God, look at all the things they're trying to address, and it never got to be urgent. And it will never get to be urgent, except now we're beginning to talk about health care as an economic. And that's one of the big differences, I think, with the Obama administration. They're realizing, his top economic advisors are realizing, we will not fix the economy unless we simultaneously fix healthcare. America's businesses, Starbucks is spending more on healthcare than Coffee Beans, GM, who knows where they are, but they're also spending way more on healthcare than they're spending on steel. They can't stay competitive. United States businesses spend about $1 for every 63 cents that other countries are spending on healthcare per individual. You can't compete that way. Personally, almost 50% of all home foreclosures are not because of the subprime. Almost 50% of home foreclosures are because you've had some kind of a health issue in the past year. And at least 50% of personal bankruptcies are because of health care issues. And state and local governments, you've been through what just happened in Maryland, you've been hearing what's been happening in California. States have to balance their budget, and they can't do it because so much of what they're spending is on health care cost. This shows that for every percentage increase in the unemployment rate, and you know that you've been hearing those, we're now at about 8%, what percentage of people are on uninsured and Medicaid? And you can see it growing, the light at the top. So with every percentage increase in the unemployment rate, the number of people that are uninsured and the number of people that are on Medicaid or the state children's health insurance program. And over here is how much then the states are paying for it. Here we are again at 8%. They're spending $20 billion on average. But if we keep moving to 10%, which we think is going to happen, states will be spending $32 billion, and they can't afford that. And when they've got to balance their budget, they're taking it from someplace else, education, other services. And this is just visually over the past 2 years what's been happening both with the uninsurance rate and also then with the unemployment rate, because obviously they're so tied hand in hand. First steps, I won't go through all this. You've probably been following that one of the first things, I think within 2 weeks of the inauguration, they signed the Children's Health Insurance Bill. An extra 11 million children are going to be covered under that. And one of the big things was dropping a mandatory waiting period for legal immigrants. They had to wait 5 years, now they don't have to. The second thing, when he was here, when Obama was in for a month, was the stimulus package. And the stimulus package was huge. There is preventive, we've got, it doesn't look like a whole lot, but prevention and wellness programs, $1 billion. And these days, $1 billion doesn't sound like much with these trillions it worth, but that's not a bad amount of money. We've got comparative effectiveness, and that's the science that Shelley's talking about. Better understanding what works and what doesn't compared to a placebo, compared to another. Which ones should we be moving towards? NIH, $10 billion, that was a third of their budget. They went from 29 to 39 billion dollars, huge. Health IT and workforce issues, and the workforce issue we're moving towards is trying to encourage primary care, as Linda pointed out was so important. So healthcare reform, Obama, when he first started talking about healthcare reform, he started talking about making sure that we build on the current building blocks of what we do well in the nation. And these were the kind of the three tenets that he was talking about. Quality, affordable, portable health coverage for all, modernizing the U.S. healthcare system to lower cost and improve quality. Can we do that simultaneously? I think folks in public health probably know that we can. And then promoting prevention and strengthening public health. And I'm going to focus a little less on the latter because we've talked about that, and I'm going to talk about the top two. These are the 7 principles that President Obama put into his budget when he said, I wanted to create this reserve fund of $634 billion, and I found money in the budget. The administration found that money and said, here's a down payment on what I think we need to move healthcare reform. And this is what he challenged Congress, very different than what Clinton administration did. Clinton administration wrote the health reform bill and presented it to Congress. He's challenging Congress. Here's a pot of money that we found in the budget, and here are the 7 things that I want you to focus on as you move forward and as you create moving this brand new healthcare reform bill. So the first, so I'm going to do the who's covered, covering all, making sure that we have the most number of people, we're spending all this money, having them all be insured. And then the second piece I'm going to focus on is cutting cost and why we can do it in a way that ultimately increases the value. So this group probably knows this, but I'll just quickly, who is covered by what, because this will be the areas that we need to focus on. So you can see from here, over half of all Americans have their health insurance through their employer. About 15% are uninsured. And what's different about the next slide is if we take the seniors out of the picture, if you take those that are mostly on Medicare, you see that 61% of folks are getting right now their insurance through the employer-based system. So we have to look at that as something to move forward and expand that. We're going to expand all of these, but that's something that's so critical and on the table. And then I think this is something that's so important over here, the work status of the folks that are uninsured. 70% of them almost are working. 70% have one or more full-time workers, 70% of the uninsured, and 12% have someone who's working part-time. So only 19% of folks who are uninsured live in a family where no one is working. Family income, just showing that the poorer you are, obviously, the more likely you are to be uninsured, and the age breakdown. And you can see that folks often talk about this 19 to 29-year-old, but you can see a huge chunk are also 30 to 44, also probably working. And this slide just shows when folks are talking about, I was just at a meeting the other day and the Business Roundtable was there and they said, yeah, the problem is that all these really wealthy people who are not buying the insurance and they can afford it. And it's true. There are a group of people in the United States that choose not to purchase health insurance. But when you look and see 35%, the green here is the percentage uninsured according to poverty level. Almost over a third of the poorest are the ones. So the disproportionate poor folks are the ones that are not insured. And does it matter? Does it matter health insurance? And this is going to be similar to the next slide. These are questions that we asked of people. We didn't ask. Kaiser asked this question, Kaiser Family Foundation. And folks that had no usual source of care. You can see the difference. The purple is uninsured. The green here is employer-based, and the 4 is a private, public plan, Medicaid, Medicare. No usual source of care. Obviously, almost everyone that answered yes, that they did not have a usual source of care were uninsured. Postponed seeking care due to cost. Almost everyone that answered yes was because they were uninsured. And they go through, you can see the purple being the uninsured, didn't get care, but didn't get it because of what it cost. Last contact with the physician was greater than 2 years ago, and this is kids. This is really important here, too. Unmet dental needs due to cost. You probably have all heard about DeMonte Driver, who was a young man in Maryland who died because he didn't have access to a dental. And so the last two there are a dentist. And the same, although the lines are different, the same for adults. So the folks that are uninsured are not getting the care that they need. So now, I don't know whether you guys have heard, but all over DC, everyone's talking about we have to bend the curve. We have to look at the projection of growth in the United States, and we've got to bring it back down again, and how do we do that? The current head of the Office of Management and Budget, Peter Orszag, who used to be the head of the Congressional Budget Office, said the single most important factor influencing the federal government's long-term fiscal balance is the rate of growth in healthcare cost. So the whole economy, the most important thing is healthcare. And so this is just over the past 45 years, how healthcare has grown. You can see the growth, and we just took that same growth and then projected it for the next 75 years. And right now, we're spending over 16% of the gross domestic product is on healthcare. And as we project out, in 2082, 50% of our gross domestic product would be spent on healthcare if we didn't do anything. So 1 out of every $2 spent in the United States would be spent on healthcare costs, and we just can't afford to keep doing this. So then folks say, well, what is happening here? What's causing this excess cost? And many people are speculating it's because of the baby boomers. They're putting us over the, and in fact, they're not. You can see here the percentage at the bottom, the effect of the aging population on this growth, but the rest of this here is the effect of excess cost growth. And what does that mean? Well, there's a group up in Dartmouth, some of you may know about them, the Dartmouth Atlas Project. They started to look at what this excess cost was, and was there a way that we could actually get a handle on it? And here's a map, and this map shows the cost per Medicare beneficiary. How much per Medicare beneficiary are these regions, and they're smaller than states, are these regions spending on Medicare? And they controlled for sickness, they controlled for the disease, they controlled for everything. And what we see here is down here in Texas, Louisiana, the dark places, bits of California here, and some of the folks up here in the Northeast are spending up to $14,000 per person. Yet the same population, we're talking about Medicare folks, and you look at the big red square states up here, North Dakota, Minnesota, Wisconsin, they're spending only $5,000 to $6,000. $5,000 to $6,000 per person, $14,000 per person. Same people, same diseases, they controlled for all of that stuff. Why is this happening? Why are we doing this? Well, so then you would ask, well, maybe which one is the right one? Which is the right number? We don't really know the answer. Maybe the folks down here in Texas and Louisiana are getting the proper amount of care. So the next thing we looked at is, what are the outcomes? We spent all this money, what are the outcomes? And what this shows is the ratio here on the axis on the left here is the quality rating. How high are the outcomes of per state? And here is the cost, up to $8,000. And here, wouldn't you know, for only $5,000, this cluster here at the highest rating are Minnesota, in Iowa, Wisconsin, Minnesota, the states that, in fact, are the lowest cost. The lowest cost are getting the highest quality. And down here, as you can expect, is Texas and California and Louisiana. So the places where we're spending so much money, worse outcomes. And that's where we're focusing now on what we do with policy. How do we move forward and change that payment structure? And surprising? No, it's prevention, it's wellness, it's primary care. And that's the difference. We've seen, they've done a ton of studies here over the past 20 years, and they've looked at proportion of specialists, and specialists, because where there's the opportunity, we have created an incentive in reimbursement to move towards what's expensive. So to go on that, how do we have created an incentive with the way we reimburse. We reimburse for high value, high volume, high intensity services. And we have then created the practice of medicine has moved in the direction of providing care that way. As Linda said, there is no incentive for primary care. There's no incentive for wellness. And it's not that providers wouldn't want to be offering this care, but they have to balance their own budgets. And we've created a mechanism for, if there are not enough primary care providers, we move them into the hospital. Is the hospital the right way to take care of diabetes and chronic conditions? No. So we have to change the way we reimburse healthcare, and we're going to start with Medicare, hopefully, and look at how we're reimbursing it, move it more towards value and less on volume. evidence-based care. We now know that probably lots of those things on the map in the dark areas are not necessary services. JAMA came out recently reinforcing a study that said most folks with arthritis do not need arthroscopic surgery. Why are they getting it done? We're now learning that a lot of these stents are unnecessary and actually causing more harm. We need to understand that more, and more is not always better. And that's something that we have to convince Americans. More is not always better. Sometimes watchful waiting, see how you're doing, drug management is the right way to go. And care coordination, and that's what folks all over the place are talking about. When you've got these individuals with chronic illness, one of my favorite statistics is of all the people with diabetes, only 10% only have diabetes. So 90% have something else, and who's helping them manage it? And that's something else we've seen different internationally. They do a much better job helping someone manage that system, helping them coordinate care, and here we don't. Everyone is in a silo, and in some ways it's because of the way we've created a reimbursement system. And then having patients involved more in decision making. What the Dartmouth folks have found, that if you really tell them what's involved in these services, they might go, you know what, let me wait a bit. Let me see how I'm doing, because I don't necessarily want to go there. But in fact, when we go to our providers, we say, what do you think I should do? And we take that advice. How do we cover the uninsured? We just, the way we're thinking about doing it, and the policies that we're looking at, if you'd like to see kind of where I think the movement is probably what Senator Baucus, who is the chairman of the Senate Finance Committee, he put out a white paper, talked in broad strokes, but kind of the direction that we needed to go. And quite frankly, when you talk to experts, they're all kind of convening that we have to look at the public programs. We have to expand Medicaid and have it be more population than just women and children. Do we need to have folks that don't have children also be eligible if they're poor enough? We need to have some states increase who's eligible. It shouldn't be just 33% of the federal poverty level. Let's increase it to 100%, and there's no standardization now. We need to allow all those uninsured folks who can't afford to buy in the individual market, the individual insurance market, which is so expensive because they don't have the bulk buying that the employees have. We need to create a system where they can buy in at the same rate or a similar rate that some of the big companies are doing it. And we need to then strengthen the employer-based system, and some are saying that we need to require some level of care by some level of guaranteeing health insurance by certain companies and how big they are. And so lastly, what can you do? And one of the things I think that's the best way to begin if you wanted to get involved is to hook up with your professional organization. Everyone probably has some professional organization that they're involved with. And they're down in DC and they've got their finger on the pulse of what's going on. And one of the things that I suggest is every time you turn on your computer and you go to your Internet Explorer, your Firefox, some homepage opens. And if you really want to keep abreast, have that homepage be the American Public Health Association, or your physician specialty group, because a lot of those folks are going to let you know you need to send a letter to your congressman. And usually what they do is they have the information right there, you fill in your name and address, hit send, and now your representative has heard from you and let you know what you think is important. The second is, if you can, get to know who your congressional members are and their staffers. One of the things that struck me, and you've probably heard over and over again, is how young and inexperienced a lot of these staffers are. However, they're very empowered to be moving lots of this legislation for their bosses. And if you have a relationship on an issue that you think is important, for example, injury prevention, you can bet that if there's some kind of a bill that's happening down there and you call them and say, hey, it's me, remember, and let me help you figure out how does this bill affect the folks back home, they will love that input. Now, if you call and say when they're in the middle of budget season, hey, this is who I am and this is an idea I have, it may not work. So timing is everything. But if you can let them know when there's a piece of legislation that's happening that you're out there and you're willing to help, I think that's a great thing and usually a really good resource. And then you get to know them, you establish this relationship, and quite frankly, a new bill, a new piece of legislation that you might have an idea, you've got this relationship. And remember, the reason that they're in office is because the folks back home have voted for them and they want to hear from you. And I think that whenever you're down in DC for a professional organization meeting, make sure that you make an appointment to go meet with the staffer. The staffer usually has flexibility. Ask for 15 minutes. Let them know who you are, what your issues are, and especially now as we move with healthcare reform. There are so many moving parts, and if there's a certain issue that you think needs to be part of this, I think take that opportunity to let those folks down there know, and also then offer to help them work out any of the details. Remember, you are the expert. It's one of the things that I think people, when you're at a place like Hopkins, you realize, oh my goodness, all these folks know so much more, but when you're comparing yourself to back down there on Capitol Hill, you really are the experts on all these things. So thank you.
What an amazing agenda. And what amazing optimism. There's some scary messages in there, a little bit of pessimism and great common themes. What I'd like to do now is open it up and have a discussion. There, clearly we saw very strong messages about the importance of science. Perhaps that friction between prevention and primary health care, as always, as we know here, is there in terms of the spending. We heard a little bit too much about hula hoops. But that is a part of my daily workout, as Shelley knows. But I would like to open it now for questions. I also want to welcome folks who've been listening over the internet, and I know that they might be writing in with questions. And yes.
Thank you so much for coming. My question goes to Dr. Whelan and all three, but you mentioned a good part of getting involved with a professional organization. I wanted to ask your opinion about avoiding the fracturing within the public health community and the health policy community in terms of universal care versus, guaranteed coverage. How do we get one voice together so we don't end up fracturing in like we did before?
And if you could just say a little bit about the question so that the folks on the internet can hear the whole.
So are you asking questions like single payer versus universal coverage?
Right, because the 7 goals are fantastic, but how do we make sure that those get passed in terms of so many opinions within even the healthcare professions? How do we get it?
I think it's a really important question because I think once we get into the details, like for example, there's folks talking about we want to cover everyone and we want to provide universal coverage, provide insurance. And then there's folks that say, well, that should be a single payer system. We like the way it's done and very successful in other countries. And when we get down to these details, I think that there is sometimes folks saying, but it needs to be like this or we won't move forward. And I think backing up and remembering which is why I started with the 3 basic pillars and then to the 7, what is the most important thing? And I think also then a dose of realism. We are not going to fix the system completely with a bill that's going to be marked up in May, go through the committee process in June or July, debated in August, and then passed in September. It's just not going to happen. So I think part of it is also to think about what are the building blocks that might help us to get there. Well, having more people part of the system, especially if we're going to look at cost-cutting measures, we don't want those cost-cutting measures to go to balancing the budget. As much as I think it's important, we have to make sure we use that right now to cover the uninsured. So looking at what our priorities are at the topmost level, and it's having most people having access to the system and the best, and realizing that we can then suggest ways to get there, but can we as a professional organization agree on what the principles that we think are the most important?
Other comments from the panel? Shelley, I'd like to ask you a question about food safety. We're all very happy about Josh and Peggy at FDA, and you're right, FDA hasn't been on the radar screen for many of us in public health quite as much as other agencies. And you said you think it's time, and I'd like to get your comments on that, particularly how it might relate, and I invite all of you when you comment. We have many of our colleagues from state and local practice here, and there's the big picture of the national agenda, but then there's an awful hard time these days in the real world of the cubicles of our health departments. And I'd like to ask you how this might reflect on the practice of public health at the state and local level as well. So if you might talk about food safety a little, Shel.
How many of you eat peanut butter? How many of you still eat peanut butter? Good. Food safety has been on the radar screen. In fact, the Government Accountability Office has put it as one of the top priorities for the incoming administration to be fixed, which is a sea change in terms of that issue finally getting its time. But it has been broken for over 20 years, and much of it is a reflection of it's always someone else's job to be dealing with the various problems. Right now, there are approximately 35 federal agencies that are responsible for different parts of food safety problems. So depending on if the pizza has meat on it. It is regulated by one agency versus another. If it's an open-faced sandwich versus a closed sandwich, it goes between two different agencies. That is true also at the state level, where there is often a mix of responsibilities. No one's really sure who's on first and what's on second. We're going to start doing that comedy show. But food safety has been, unfortunately, in this forgotten elements with such a Byzantine maze of regulatory responsibilities, but no money, few people, and no one clearly following the ball. This most recent incident with the Peanut Corporation of America highlighted many of the challenges that have been long known, where FDA was having Georgia Department of Agriculture inspectors playing a role, but they had not been trained in the specialty of peanut contamination problems. Many of those companies were relying on third-party inspection processes, but those had become captured operations that if you didn't give good ratings, you probably weren't going to get the business again. It's not a very good check and balance system. So I think it's finally, whether it was spinach last year, tomatoes misappropriately being identified as a recent salmonella outbreak, when in fact it was jalapeno peppers. It's a Keystone Cops type of scene. You have so many industries who have actually recently been hurt. This most recent recall, and it's important to point out, FDA does not have recall authority. So when there's bad food out there, they can't order a recall. When they're actually bad medicines, they can't order a recall. It's voluntary. They have to ask the company to voluntarily take those contaminated items out of the food supply. It's where we did not know where the peanut butter was, which products might have been contaminated. Many businesses got hurt, and we're actually at a sea change point, because industry is now stepping up, where in the past they've been saying, don't regulate us, we'll take care of it, to a realization that there is a role and responsibility of government to set baseline standards, to have assurances about the quality of the consumer products you're using. And everyone gets hurt when that basic health is at risk. So when you have grocery manufacturers America stepping up and willing to now negotiate, that's significant. When you have Kellogg, the CEO, I think it was last week, testified before Congress saying, we fought it in the past, we're ready, we need change, we'll play a leadership role. You have only a handful of public health experts in Washington who have been championing this for years, who've been lonely and forgotten, who now it's their time. But it is political will, it is having people like Peggy and Josh, but also leaders in industry willing to also step up and say it is time. And the science has been a slam dunk for quite a while. So there's some very specific reforms, whether it's the DeLauro package or a Durbin package, it'll be some kind of modification in the near future. I'm quite convinced it will pass this year, which it's only taken 100 years to get there.
I think just two other points about that. It's become urgent. You know, it's one of those things that we needed to do it for so long, but now it's so visible. And I can tell you from being on Capitol Hill, everyone's writing in. When that spinach crisis happened, everyone heard. And it's also not partisan anymore. Everyone's eating peanut butter. This is affecting everyone in a way that everyone is looking out for this. And you see the big square red states who are growing this stuff, and they're affected when you put this, look what happened with tomatoes, and it wasn't even tomatoes, and everyone that were the growers of that. So I think you're right, that this really has come, and we have to take this opportunity and really use it to move ahead.
Fran.
Okay, so there's just so many great ideas here. I don't know where to start, but I'll start. The first thing is, Shelley, I want to say that you talked about some of the things that the new administration has done to revitalize the whole landscape, such as recognizing the value of science. One of the things that I think is going to have a profound impact is recognizing the value of government service. And whether it's at the federal, state, or local level, the ripple effect of that is to say this is an honorable thing. To work in public service is something that can make a change, and that it is something that people who are mission-oriented young people can really attach their careers to. So I think that there's all the way through the levels of government, I think that that's going to be very positive. Now, okay, peanut butter, and we all love Josh, and we're so, I gave him a list to take to FDA. But here's the thing about that. The thing that's the most unsafe about our food supply is something that FDA, as urgent as this is, can't address. And that's what's really burdening kids. If you look around in classrooms, it's not because there's some random salmonella in some sandwich. It's the food environment. And so it's coming back to something that's primary prevention. It's tough to regulate because there's some tremendous, I'd love to see the CEO of Kellogg come out and say, okay, we're going to take a whole new look at childhood cereals. You know, not from the food safety, but from what we're doing in developing the next generation of chronic disease. So, okay, having said all that, what can public health primary prevention interests, how can those interests be advanced in this moment in time, which is very, very sympathetic to looking at ensuring people, cost containment, looking downstream, but how can we get some of that, more of that primary prevention embedded in the discussion? So,
Can I start, and then I look at food safety, I actually use the language food safety to be a more systemic conversation about food. Food safety for me is the excessive levels of salt in processed restaurant foods. AMA challenging our regulators, our members, our policymakers, that a 50% reduction in that use of excessive use, it's not for taste purposes, for preservation and weight addition in foods, would save 150,000 lives per year, according to AMA, if we had those reductions in processed and restaurant foods. Sugar, getting into the obesity issues, whether it's trans fats, looking at how we're producing food overall. I mentioned antimicrobials. That is just the tip of the iceberg of how we're functioning in terms of our food production system, or what I would actually beg to say that we're not producing properly food. The amount of investments, subsidies, and activity going on in the food supply is not about a healthy food supply. And I actually just came this morning from a conference that was sponsored by Kellogg and Robert Wood Johnson and many others to bring together the sustainable ag, the food nutritionists, the childhood obesity arenas, these different silos in public health, to pull together and say, we've got a food crisis taking place, whether it's on the production end or on the quality. And quality, again, the pathogenic issue is just, it's almost, I didn't say that publicly, but it is the tip of the iceberg. I'm going to start doing lettuce things. We must approach this systemically, and we're not. But I think that we actually are signs of leadership. Secretary Vilsack, I appreciate almost the food fight that's starting to line up of him as USDA leadership, talking about food safety, and in a vacuum as we don't have an FDA commissioner, actually making a move of they are going to lead the charge on reforming our food safety issues. I'd love to see that type of fight take place. That Obama has made a commitment to a White House-based working group that is going to force all of the agencies, the many that are out there, looking at food issues, again, not just in terms of pathogenic contamination issues, but looking at the broad scale, how can we do it and how can we do it better? And I applaud Michelle Obama out there with her shovel. I think that is a symbolic first step, that we are going to focus on food, and whether it's about an epidemic with our children and obesity, or it's that they shouldn't be worrying about Sasha eating peanut butter sandwiches 3 times a week, that food is going to become foremost a health issue. And in fact, 4 years from now, we have Farm Bill coming up. And many in this room have been thinking about and talking about perhaps next time it's food bill. There's some big changes coming along and big signs. And in fact, this food safety bill is just step 1.
Linda.
I think another piece of it too is some local issues that people need to start dealing with, and that's the availability of healthy foods in the community. So there's so many communities where there's lower socioeconomic status and you can't get fresh fruits and vegetables. So what are they going to eat? And what do the kids learn how to eat? What's advertised and marketed to kids? What do they see? They see unhealthy foods really marketed to them. So, a Happy Meal at McDonald's, is what they grow up on or something. And this is how they learn to eat. So we have to also look at some of those issues and focus on that and advocate for making those changes.
Molly, do we have questions coming in from that you would like to read yet? No? Okay.
Could Tom show the hula hoop demonstration?
I wasn't going to read that one aloud.
It's a true story, but it's not appropriate for this forum. There's a California website that has great weighted hula hoops that I recommend, but yes, in the back.
Thank you very much for the presentation. I was very interested in seeing the relationship between quality of care and cost. And obviously, we are now entering in a new public health paradigm in which new information systems should produce better performance measurements. And I think there is a need of new metrics in public health. Most of our tools are updated and they are needed to be adjusted. And I think we don't have accountability measurements and metrics that will allow us also to monitor the responsibility of the industry, the private sector, the civil society, and even the scientific community, because the knowledge that has been available has not been applied, and we need to accelerate that in public health. What do you think about the addition and the development of these new metrics that will better monitor the performance of our work in public health?
I think that comes up in almost every discussion that we're having on payment reform, because we can talk about let's reimburse based on how you deliver the care, but ultimately it doesn't matter how we deliver the care. What matters is if the patient does better. And to date, you're right, we have not had the ways to measure and be accountable to the patient improving. Because we can pay more for the person who delivers good primary care, but if we can't measure the patient ultimately doing better. So we're actually working closely with some folks who are looking at health IT and make sure, whether you saw, there was $19 billion in the stimulus package looking at health IT. And we want to make sure that that doesn't just mean everyone gets new computers. We want to make sure that when we develop the health IT, it happens simultaneously with payment reform, with the eye towards not only individual, but how do we look at community issues that are being influenced in the health level, in the health delivery system level. And what we think is, if we start to create a mechanism where someone says, you're going to get paid if you can measure outcomes, we think there's probably a whole group of innovators out there who are ready to help us try to do that. The knowledge is there. It's a hard thing to measure. And I finished a postdoc with Barbara Starfield and Chris Forrest on primary care, and one of the reasons was because when you do primary care, you prevent it, there's nothing to measure. So how do you measure good primary care? Well, so whenever I was on Capitol Hill and we started to talk about something and we wanted to see if this did a better job, and people said, yeah, we can't measure that. Let's measure this because it's easy to measure. Well, then we're going to just have everyone playing towards the test of what's easy to measure instead of saying, yes, it's hard, but unless we put that in there. And I think health IT and thinking about health IT simultaneously, and then having payment reform not just be an extra payment on top of if you did a good job putting these mechanisms in place, but it's kind of the pay for performance, but it's also making sure it's broader than that. And having the patient involved. Should the patient be the one holding that? And I think those kinds of questions. And what we're going to try to do is have the health IT discussion come simultaneously with an eye towards those things. I think it's a great question.
In the back.
I'm Marjorie Buchanan from the University of Maryland, and I have a question about the silos situation. Investments, we still continue to talk a lot about patients, and I think the population focus is an essential discussion that we have to have. And for every investment that we make in healthcare dollars, so often the outcomes are, from a long-term point of view, are felt in the education field, in the workplace, in the criminal justice field, and those the intersection of the economics in each of those sectors don't sufficiently overlap, so that our investment ends up in a cost savings on those ends, and I don't think we're doing it well enough to bring those forces together.
Comments from the group?
A lot of nodding of agreement.
And for those of you who don't know, Marjorie's been doing public health for years and years. It is a great public health nurse who's been doing this for a long time. It's such a great point, and I think one of the things is it's so hard to do again. And one of the things that I think could really advance it is if we were able to get some pilots, people that are in the field, knowing that if I do this, and I do this prevention here, and this kid is not going to go into the juvenile justice system, can we then start to measure things like that? And you know, that's really what folks like at Hopkins can do. People that are thinking about the data and how they maybe could overlap. What we're hoping, and what I'm seeing now just with payment issues, but I think will happen otherwise, is we're looking to good ideas. What are some of the innovations? What are the ones that are happening at a local level? Could we beef them up to a state level? And are there enough data, and it goes back to data collection, that we can say this is enough to then implement broader? But quite frankly, those silos is what could kill it. And if you have folks at the local level who can come up with some good ideas and try to branch it out, hopefully we now have an administration that might be able to think about those things as demonstration projects and move it into some legislation, because that's the only way. I mean, public health is that's the problem with public health, that it is everywhere, and there is no single, you know, we're doing appropriation bills right now, and there's this bill and there's this bill, and public health is beyond that. And Medicare and Medicaid isn't it? You do a better job in Medicare and you prevent Medicaid from paying for the long-term care. Even in that little silo, it's hard to figure out how to do that. And what you're talking about is the direction, and I think we have to help those folks who are now open to hearing these things, give them some ideas of what we might be able to do.
Yes.
Dr. Hearn, you talked about having leadership in the right places, but just, I don't know if it was today or yesterday, there was 61 votes against the reconciliation process for climate change. And a lot of surprising votes against that. How do you reconcile such inertia for the status quo, you know, with leadership whether at heads of agencies or in the executive branch that wants change and advancing these priorities, but yet the legislative inertia that is really going to work against that?
That's a good question.
How do you reconcile many of these pieces? Global climate change has had phenomenal shifts. 10 years ago, it would not have passed the laugh test to even have as many bills up for consideration today that we do. I actually, perhaps it's the gray hair, but as I look to where we are today, I am stunned that something as esoteric as this issue, and it's esoteric in terms of this is one of the most challenging issues to wrap your head around, that has been because of some very significant leadership in many different places that has put this on the radar screen, and in fact the political will angle is one that's going to move this. I actually think this can go forward in the next few years. I think you're going to see an extraordinarily sophisticated political campaign activity take place that has been responsible for getting it to this point, which I don't know how many of you have been tracking it, but again, I think it's stunning to the achievement of the bills that are out there. I think that you're going to see a sophistication that is unheralded, unprecedented in the public interest community, from the amount of money that's going into C4 activities with the advocacy community. You have literally hundreds of millions of dollars that are going into phone bank operations, that are going into very targeted districts in the Congress of where you see some of that recalcitrance and some of that hesitation. They are being targeted in the activities, whether it's now shifting into political giving, to advertisements that are targeted to either we're going to vote you out or we're going to put the pressure on that you've never seen, and also industry leaders. Some of the top businesses that have stepped forward and said they will start spending some of their political capital. I would not have bet on this issue 10 years ago that you'd see change in 10. It is here today. You're going to watch what happens because it's something where public health can learn significantly from the sophistication of moving complex issues that are against some very strong opposition. And we're going to see not the best bill, but there's going to be some significant compromise provisions that are going to go forward that watch, it will happen.
Ruthie.
So I think it's great that health reform has finally come to be a front burner issue down in Washington. But part of the reasons that it has become an issue was that it's tied with the economic crisis, and that health reform has become an economic issue. And so I'm wondering what you think the public health implications are of making health reform an economic issue instead of just a health or public health issue.
So I think the quote was, to fix the economy, we have to fix healthcare.
Yeah.
I wrote that down. Good question, Ruthie.
Yeah, it is a good question. But I think the public health implications are that it's actually now this opportunity to do something about it. I'm not sure it's a bad thing that it's being tied to the economy because people weren't going to look at it before. And in fact, the way people have tended to view public health is, oh, that's sort of those services for all those people who don't have any money, you know. And it's not been something that is well understood by the general public. In fact, you know, how many of you who are here, how many of you know, do your families understand what you do? You know, right? You know, if you're a doctor or a nurse, they can kind of get that, you know, but if you work in public health, it's a little hard sometimes to explain what it is. So I think it's maybe to our benefit that it is being tied to the economy and that people are realizing that you have to do something about health in order to have a good economy.
So we're getting a little short on time. I'd like to, for each of you maybe to close. So we're in this ivory tower here, Hopkins, and we see all this great change happening down the road. And I get a little nervous that there's a disconnect between the schools of public health in general and the reality of the issues of leadership and science and moving things forward. So I was wondering if you might be willing to close with some recommendations for how the school can be more involved, better prepare our students to participate in this process and help move public health ahead. So, starting with taking Shelley's course, which I know she has to teach right after this. But, yeah.
How many of you are in that class? We're going to be a little...
You're going to be a little late.
I'm still here reconciling your question. And I'm going to start there because I want to point out because Congress did not pass reconciliation. Reconciliation is considered right now a nuclear bomb approach. And I think the fact that it's not being voted on and being saved potentially for the budget and healthcare is a reflection that global climate change has actually become a bit of a bipartisan issue. And you do have bills that have both parties on. And I don't think they're going to need the reconciliation piece in order to have passage. And in part, it comes back to, there's some lessons that have been learned over this past 10 years of moving this that apply to public health. And I'm going to go back to what I said at the podium, which was leadership, science, and political will. And the translation piece for schools of public health, that I think it is now more than ever the time for the public health field, in particular our next generation sitting here, that those leadership positions are desperately needing the people who are trained in science and how to translate it and how to take risk in those leadership spots. It's not by happenstance that people like Peggy and Josh are coming in. Many of you are the next Peggy and Joshes. In fact, Josh, I think, is, well, he is younger than me. I won't go into. But also,
Josh really is 39.
Yeah, I think he's 29. Your point, I actually don't know your name, but it was a very important one on public service. It is an honor, and in fact, I pray that many of you in this room do take a stint in government service. I think it is not only desperately needed, but I think it is a public health duty. And it is where some of the best opportunity for change and impact, having come out and had time in a government agency, I've never learned more, and I've also never had an opportunity to have as much inside influence to actually move change. So the public health agency desperately needs you. They are extraordinary learning opportunities, and it is how it will stage you to play those leadership roles. Science matters, and it's places like Johns Hopkins that keeps its eye and is focused on the quality and credibility of the data and making sure that the data is not used to try to make a point that it's not meant to, but really staying true to what the science says and being an honest, the truth teller that plays that role to make sure that really is evidence-based decision making. And political will is part what you were talking about. The room here, your expertise has extraordinary power and credibility. The American public trusts nurses most. Doctors come in a very close second. Public health leaders, well, I think they're off the charts, but I don't think we've actually polled specifically on public health because no one knows what it is. But you're trusted. And use that credibility, honor it, but use it to speak up, because public health is about translation. It's not sitting in a research lab. It's about taking your information and knowledge and showing up at those offices. That's where Johns Hopkins and the field can make the most powerful difference, is bringing your science, bringing your leadership, bringing it to the people who need to hear from you.
Linda?
I would also like to add that faculty need to serve as role models for students in doing that. It's a little bit more of a challenge. But I think that often we don't see faculty really engaging in advocacy or in taking their science and translating it so that it can be used. And I think that's the challenge. Yeah, the translation is the real piece of things. And I think teaching students as part of their program how to translate data so it can be used by advocacy groups, how to speak to the media and not be afraid that things are going to be twisted, because you have a lot of people who are scientists who worry about talking to the media and getting the data out there, because they always, they'll say, well, they're just going to twist it. So the question I often ask is, if you write a paper and it sits on somebody's shelf, yeah, it gets you promoted, but does it make a difference in the world? You need to be able to take that paper and take what's in it and translate it so people can use it when they go to talk to policymakers on the Hill, when they go to talk to people at the local level. And we're not always very good at teaching people how to do that or at doing it ourselves. So I think it's one of the reasons I'm not a professor. So is that I haven't written enough. I spent too much time doing advocacy.
We are working on that here, believe it or not.
But I think that's really a critical piece of it. And I think that the other issue that I have with a lot of schools of public health is that often their policy divisions or sections or whatever focus so much on health system policy that they really ignore public health policy or policies that affect health. And I think we need to make sure that we have people who have similar kinds of roles, economists, other people who are thinking about the impacts of policy, but are looking at broader policies that affect health. And sometimes we have to reach outside the walls of the School of Public Health to get people from other parts of campus or from other disciplines to work with us on some of those things and teach them how much their policies are affecting health.